talk a bit more about femoroacetabular impingement, FAI. What would increase its potential? How would it be seen in measuring? And what kind of interventions could we pick? Awesome question, Doman. So FAI, basically what that is there's bony adaptations either at the femur or the acetabulum that could potentially be restricting motion. You have, well, 3 lesions technically. A cam lesion would be a change in bony bone shape at the femoral head. A pincer lesion would be bone change at the acetabulum, and then a mix would be changes in both. And these changes could be a structural block that could limit your range of motion. That's the big thing with impingement. And generally what you'll find is you'll go into an end range. A lot of times hip flexion is very common, and you might hit a restriction, and it could lead to a pinch in the area that you're trying to go. That might be an indicator of femoroacetabular impingement. Now, the thing with FAI, which is what it's called for short, is that you can't change the bony structure as a clinician or a coach. The only thing that we can change is the amount of movement options that are physiologically available. So I could have bony restrictions being a limiter to my range of motion deficits. I could also, though, have neuromuscular contributions that could be limiters of range of motion as well. And your job is to differentiate which of those you're dealing with. How would you go about fixing that? You would do the same things that you would normally do with some type of movement restriction. So what that might entail is if you have someone who's limited in hip flexion, well, you have one of 2 things to focus on. Maybe it's flexion and IR. If they're limited in flexion, you might need to do things that counter-nutate the sacrum. So this could be something like drunken turtle or something like a hook-lying tilt. Anything like that that's going to drive more counter-nutation of the sacrum. There was a cool study done that I'll link in the show notes where they looked at how changing pelvic positioning can influence femoral measures. And when they created, or when they drove an anterior pelvic tilt in femoroacetabular impingement patients, that actually led to a loss of internal rotation. So if you can't stack, don't talk to Zach about your FAI, because maybe if I can create a posterior tilt, that can restore hip internal rotation limitations. The process does not change. You would still do the moves that you normally would do. But here's the issue. Let's say you do a bunch of stuff and you don't get any changes in motion. Then what you likely have to do is refer out to see if you can either get some imaging, to see if there's something that can be done about it. In the last, I don't know, it seems like I had an epidemic of these, but in the last couple months, I've had a couple cases like this where we did a bunch of stuff, and both gentlemen who had like 90 degrees of hip flexion, and they were young, so it's like, this seems a little wonky. So I tried to do everything I could, and the funny thing was, well, it wasn't very funny, but we got great changes on the other leg, but the side that was affected didn't budge. And so I recommended that they go get imaging just to see what could be done. And maybe in that case, they could have some structural issues at play that need a surgical procedure to change. Because sometimes unfortunately, the structure is going to influence what the heck is happening from a mobility perspective. And you have to do things to address those limitations. And I mean, it sucks. It's not fun because you might have to undergo a surgical procedure, but it could be life-changing in the sense that you might be able to get your body into positions that you might not normally would have. Sometimes, especially if you're someone who's maybe had FAI for a while and that's changed to osteoarthritis, sometimes you might need to get a total hip. And it stinks that you have to go through that procedure, but I've known a lot of people who have had total hips that has been incredibly life-changing. So it's important that you go ahead and get that checked out. To summarize your great question, Doman, femoroacetabular impingement, bony changes to either the acetabulum, the femur, or both, you would not change a thing. You still go after improving the movement capabilities that one should possess. However, if you do stuff and they're stacking, they're able to shift, they're able to reproduce everything that you want them to reproduce, and they still can't elicit a change, you might need to refer out to someone to get imaging to see what the next step would be. Now, I don't know what the surgical procedures entail or the success rate. I know if it's like a labral pathology, it seems to be hit or miss, but it seems like that's probably the best course of action.